damage, especially from ROS, that is reactive oxygen species, and nucleases. And second, to facilitate the movement of the sperm cell by giving hydrodynamic shape. So here, during the final step of spermatogenesis, the histones will be replaced by protamines, thereby the DNA is compressed and the spermatozoa acquires the hydrodynamic shape, thereby it moves fast. And third, making DNA inactive, thereby allowing proper post-fertilization genetic reprogramming. And protein core is also a part of checkpoint during spermatogenesis and has a role in fertilization process. The next, what is DNA fragmentation? So DNA fragmentation is the separation or breaking of DNA strands into pieces, and it can be spontaneous or accidental. The formed DNA fragments gradually accumulate in the cell. So when you see the basic structure of DNA, so it contains adenine, thymine, cytosine, guanine, and these nucleotides are supported by a double helical structure, contains phosphate and hydrogen bonds. So DNA fragmentation is nothing but either single strand break in the DNA or double strand break in the DNA helical structure is considered as fragmented DNA. So unlike somatic cell, the male gamete, that is spermatozoa, doesn't have DNA repair mechanism on its own. So the DNA, the damaged DNA is not corrected by spermatozoa by itself, unlike somatic cells. And in the same way, even the detection of sperm DNA fragmentation in sperm cell is very difficult due to compact structure of chromatin and close association between DNA and protamine in the nucleus. And the etiology of sperm DNA fragmentation is broadly classified into two types. One is primary testicular events and extratesticular events. In the primary testicular events, the first one is abnormal germ cell apoptosis. So apoptosis is basically a natural physiological process where the cell is programmed to death. In some circumstances, the sperm cell escapes from apoptosis and exists in the semen sample. These spermatozoa carries more DNA damage. And second one, exposure to gonadotoxins. So gonadotoxins are nothing but heavy metals, environmental pollutants, and certain class of antibiotics which are present in the internal and external media. These gonadotoxins produce reactive oxygen species. These reactive oxygen species damages the sperm plasma membrane or nuclear membrane, thereby the DNA is more susceptible to damage. And advanced paternal age. As the age advances, the germ cell apoptosis process is less effective, thereby releasing more damaged sperm into the semen. Fourth one is sperm chromatin packing abnormalities, where in the final step of spermatogenesis, the histones protein should be replaced by protamines, thereby the DNA is compacted and compressed. So any packing abnormalities like histone to protamine replacement problems, where the DNA is loosely packed, thereby susceptible to more damage. And high levels of ROS in certain conditions like infections, where the overwhelming production of ROS again damages the sperm plasma membrane, thereby the DNA is more susceptible to damage. And in extra testicular factors, smoking, radiation, chemotherapy, and genital tract infections, varicocele, diabetes, and testicular hyperthermia, all these factors has profound effect on sperm DNA fragmentation. And one is the causative mechanism is oxidative stress. Let's see what is oxidative stress. And in general, body has natural antioxidant mechanism that is antioxidant enzymes present in the cells such as superoxidase dismutase, catalase and glutathione reductase. These antioxidant enzymes combat or fight against ROS and thereby reducing the oxidative stress. Next, to identify the DNA fragmentation test can be done by tunnel assay and sperm chromatin structure assay, comet assay and sperm chromatin dispersion. So, each method has advantages and disadvantages. So, when you see the tunnel assay and sperm chromatin structure assay, so it is easy to perform, but whereas in final analysis you need to have a fluorescent flow cytometry, that is again expensive instrument. In the same way, even comet assay is easy to perform, but need to have a fluorescent microscope and gel dock system for analysis process. Whereas in SCD is a very simple, accurate and not required any expensive instrument for the analysis. It needs only compound microscope for analysis. So, let us see the principle of sperm chromatin dispersion test. So, after exposing the sperm DNA to acid denaturation lysis solution, protamines lyses and chromatin decondenses and it forms a halo around the sperm head in agarose gel, indicates DNA is intact in that particular spermatozoa, whereas in absence of halo around the sperm head indicates damaged DNA. So, this is the final analysis of the SCD method, where you can see spermatozoa with different halo dispersion. Here you can see big halo and medium size halo and small halo and no halo. So, the big sized halo and medium sized halo is considered as normal or intact DNA, whereas in small halo and no halo is considered as abnormal or fragmented DNA. So, the DNA fragmentation level in a given sample is expressed as DFI. So, DFI is nothing but DNA fragmentation index. So, the higher the DFI and higher the percentage of sperm contains fragmented DNA. And in the final analysis process, you have to count 500 spermatozoa on the basis of the halo pattern and the cutoff value is 30%. When the DFI exceeds 30%, then that sample is considered as abnormal or more fragmented. And when the cutoff value is less than 30%, then that sample is considered as normal or less fragmented. So, then come to the influence of sperm DNA fragmentation on reproductive outcome. So, sperm DNA fragmentation has no effect on fertilization rate. So, that means even DFI is more than 30%, if you inject the spermatozoa into the oocyte, still it is capable to fertilize. But whereas in the sperm DNA fragmentation is negatively associated with poor embryo quality, blastocyst formation rate and lower pregnancy rate. And in some of the patients, even DFI is more than 30%, but still capable to conceive. In those patients, you can expect more abortion rates. So, this conclusion we have drawn from the previous published research articles by several authors and our own research publications. So, in Krishna IVF, we developed SCD method in-house in 2010 and we did one study in 2012 where we correlated sperm head abnormalities versus DNA fragmentation. Sperm with different head abnormalities such as microspermia, macrospermia and pyriforms, elongated head, all this spermatozoa is having more DNA fragmentation. So, abnormal semen morphology is always correlate with DNA fragmentation. And in the second publication we published recently, that is in the year 2013, where we correlate the DNA fragmentation and the outcome of ICSI. So, as I discussed earlier, so this DNA fragmentation does not have a role in the fertilization, but it has a negatively associated pregnancy rates and more abortion rates in these patients. And the clinical significance of sperm DNA damage, the specific conditions may benefit from the test. So couples planning to undergo IVF or ICSI, like in some of the patients where the semen sample will be normal. If you see the count, motility and morphology, that will be normal or meets the WHO criteria. In that semen sample, maybe the DNA fragmentation will be more. And unexplained infertility, where nobody knows the exact causative factor for the infertility. In such infertility cases, DNA fragmentation might be one of the contributing factor. And couples with recurrent pregnancy loss, in addition to other factors, and DNA fragmentation is also considered one of the factors for the pregnancy loss. And in conclusion, in addition to routine semen analysis like count, motility and morphology, if we perform DNA fragmentation and we get better answers and we can explain to the patient about the prognosis. I thank Dr. Ramaraju giving this opportunity, and I also thank my head Dr. Madan and my colleague Dr. Murali Krishna and the genetic department Mr. Shivanarayan and Ravi Krishna for contribution of developing HCD method and their contribution for the publication in this area. Thank you.
Thank you very much, Dr. Jay Prakash, for introducing sperm DNA fragmentation, when it is to be done, in whom it is to be done. Thank you very much. And I request Dr. Ramakrishna Raj Garu to hand over a memento to Dr. Jay Prakash Garu. Now we move on to the next topic in the session, CASA versus conventional semen analysis, merits and demerits by Dr. Murali Krishna. Dr. Murali Krishna's dedication to the Department of Embryology runs in parallel with Dr. Prakash, and they both share an excellent rapport at work. Dr. Murali Krishna has done post-graduation and PhD from Andhra University, Visakhapatnam, and he has 9 years of professional experience and a co-author of 29 publications in the field of infertility. Now I welcome Dr. Murali Krishna to deliver his lecture.
A very good morning to all of you. Today I am here to present my topic on CASA, computer assisted semen analysis versus manual semen analysis. As we all know that male factor is involved in 40% of the couples seeking infertility treatment. Semen analysis is the examination of seminal fluid, and it involves examination of spermatozoa count, motility, morphology, and finding out of volume of the semen, pH, viscosity, liquefaction, and various other biochemical parameters. And also we look for immature germ cells, WBC and RBC. We have a WHO guidelines for normal semen analysis. WHO introduced guidelines in the year of 1987, and periodically they have introduced revised guidelines. Interestingly, in the year of 2010, there was a significant difference in proposed parameters. Like volume was, now they say a minimum of 1.5 ml is a normal. And sperm concentration at least minimum 15 millions per ml, they say it is a normal. Likewise, motility, now they say progressive motility. They have combined fast progressive and slow progressive to 32% minimum, or entire motility should be of minimum 40%. And interestingly, now they say at least a 4% normal form should be there in a given semen sample. Earlier it was 50%, now they are saying 4%. So this stresses the need for accurate and precise semen analysis to be done. Most of the laboratories, they analyze the sample manually. So lab technicians, they do the sperm count and motility using an ordinary gloss slide. Sometimes they use hemocytometer, and rarely they use Maculus chamber, which was originally designed for semen analysis. Again, motility, they go for visual inspection. Morphology, they rarely use in histological stains. So when this process is adopted, there is a chance for subjectivity, inter-observer variability, inconsistent reports, and we cannot reproduce the data. Like we may not be having image and video clips. Finally, we get the reports like this. They hardly spell any important information. They just comment on count and motility. They will not tell you about the how many are morphologically normal and abnormal. Again, they may not have sub-classifications, like how many are head defects, midpiece, and tail defects. Suppose if you have a sperm count like this, yes, we can do the count and motility manually also. We can find out how many sperms are there and how they are moving, whether fast progressive, slow progressive, non-progressive, or immotile cells. We may not find any difficulty in estimating the sample like this. However, the samples are like this, which has high density. We may find some difficulties in finding out concentration as well as finding out the subpopulations in motility patterns, how many are fast, slow, and non-progressive, and how many are immotile. So there is a chance for making mistakes in finding on the correct motility patterns. So this can be avoided by using a machine called computer-assisted semen analysis technique. This is an automatic system designed for sperm concentration, motility, morphology, and also to do the statistical analysis of sperm population by continuous development of image of sperms, digital analysis, and information analysis using a microscope, camera, capture card, and a computer. So we can be sure, if we use this system, we can be sure of objective assessment, less inter-observer variability, and less inter-laboratory variability, and more of consistent reports. CASA system identifies the sperms by assigning various color patterns. The red color ones are fast progressive motile, green are slow progressive, and blue color are non-progressive, and yellow color, what you are seeing, immotile cells. And they give certain numbers. It means the number of sperms evaluated in a given sample. Even in high counts also, it never makes a mistakes. It will identify all these sperms with various color patterns. If the system left out any sperms, we have editing options as well. We can add the sperms during the analysis, and we can get the accurate semen analysis report. If you see this graph, suppose if the sperm starts its movement, this is point A and this is point B. It never travels in a straight line. It takes a curvy linear path. And system measures the sperm movement by assigning various velocity parameters. Like we have a VCL, which means total distance covered by the sperm to Java, and average path velocity VAP, and straight line velocity, and also ALH, amplitude of lateral head displacement. If you see these two graphs, this will tell you about the sperm with good motility, and this is a poor motility. This sperm has taken a long path to reach this point. There is a lateral deviation from the straight line, whereas this is close to the straight line, and you have various parameters here. So these can become good predictors for sperm motility. What I am trying to show now is zebras in African plains. All zebras look similar. It is very difficult to identify the differences between them. However, baby zebras, they identify the mother without any make mistake. They identify the mother zebra based on the color strip pattern, and they remember in their lifetime. Similarly, if you are well aware of the abnormalities, we also never make mistakes. You can easily identify the small acrosome, vacuolation, thick midpiece, and cytoplasmic droplet, and other abnormalities. We can easily make out. However, we may get confused in identifying the borderline morphological forms. What you are seeing here is normality is subject to perception. If you do not follow any tools to say any particular object it is morphologically normal, sometimes it is also an abnormal. This is a horse image and this is a frog image. If I call it as a horse, I should define it as a horse with some characteristics. Otherwise, some people they say it is a frog or it is a horse also. How it becomes? I hope it is clear now. So these are all 6 images are morphologically normal sperms. This is an ideal sperm, but slightly tapered towards mid-piece is also a normal spermatozoa. And this is slightly narrower, but we still consider it as a normal. So when you have all the 6 forms considered to be normal, if you are not using any specific tool to say it is a normal, some people they say it is an abnormal and this is normal and this is abnormal. Here CASA will help you. CASA classifies the spermatozoa based on morphometric values. It measures the sperm head length, width, area and perimeter, and then it classifies whether it is a normal spermatozoa or an abnormal spermatozoa. This is a sperm image. A digital image is created by the CASA system. The yellow portion is an acrosome region, post-acrosome and mid-piece. So these are the various ranges. Sperms which falls into this range, it classifies as a normal spermatozoa. Normally for morphological analysis, we count about 100 sperms. The system identifies based on the morphological features into whether it is a normal spermatozoa or abnormal spermatozoa. It will create various parameters, then classify it. So the question is now whether these CASA parameters really correlates the outcome. So we searched literature and when we found recently in 2011, Yoon et al., they found some of the kinetic parameters are really correlating with the pregnant groups. VCL, VSL and average path velocity are significantly more compared to the non-pregnant group in raw samples. So these can act as a predictors. In the year 2001 itself, Hirano et al. Found in classical IVF patients, they found more than 50% fertilization when the VCL, VSL, ALH is significantly more compared to the poor fertilization group. We have done a retrospective analysis in our clinic where we found in pregnancy positive group, we found head length, area, head perimeter and acrosome are significantly less in pregnant group, pregnancy positive group compared to pregnancy negative group. Acrosome was significantly more. It is less in pregnancy non-negative group, even though we did the ICSI. Similarly, the count, type A, type B, all the motility patterns, VCL, VSL and average path velocity were significantly more in pregnancy positive group compared to the pregnancy negative group. They are statistically significant. When you look at the comparisons, manual analysis involves a subjective technique, less accurate and precise. It is objective, more accurate and precise method. Detailed description of sperm movement is not possible in manual analysis. However, it is possible. And this is of inconsistent and non-reproducible, where it is consistent reports and reproducible. A large inter-observer and inter-laboratory variation will be there, whereas this is less in CASA clinics. And very difficult to meet universal quality control systems. The technique is operator dependent, whereas universal quality control system can be adopted since it is a machine dependent. A basic report is available during male factor counseling, whereas here you can show the patient and you can counsel them in a better way with real-time video clippings and images. Basic data is available here, but large-scale data is available for research studies. So you cannot store the data here, but it is possible here. This is inexpensive manual technique. The only thing is a little bit expensive CASA system. So now, a more accurate and precise analysis of semen is required post 2010 WHO guidelines. Clinicians, they must objectively assess the semen sample instead of relying on the report given by the laboratories before they are going for more sophisticated procedures like IVF and ICSI. Lab personnel must actively participate in the quality control systems to improve their skills if they are adopting manual techniques. The cost of the CASA may be gradually reduced once more and more clinicians opt the system. I thank you all, one of all, for your attention. I am grateful to my Dr. Ramaraj Garu, Dr. Madan Garu for giving me an opportunity on this occasion. Thank you very much.
Thank you, Dr. Murali, for the informative talk on CASA with apt examples. And you made the talk more interesting today. Now I request Dr. Geeta from Fernandez to hand over a memento to Dr. Murali Krishna. Now we move on to the next topic by our guest speaker, Dr. Aba Majumdar, a well-known academician and speaker nationally and internationally. Dr. Aba Majumdar is a professor, director and head of the department, Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi. Baby of North India, born in 2009. And she is a recipient of Dr. B.C. Roy Award, Nation Vikas Ratna Award, Chikitsa Ratna Award, and she is a faculty of postgraduate teaching in Obs and Gynecology, conducted by the National Board of Examination India, course director of North India for the National Board of Examinations for awarding postgraduate fellowship in reproductive medicine, recognized by the Federation of Obstetrics and Gynecology for awarding FOXY certificate to impart basic as well as advanced infertility training in her institute. And she is a peer reviewer for Journal of Human Reproductive Sciences, executive member of editor of IVF World and panel for NDTV, website queries, an invited speaker in national and international forums, as well as published original papers, more than 30. And she has participated in many conferences nationally and internationally. And she is a past president of Indian Fertility Society of India, the chairperson for the Infertility Subcommittee of the Association of Obstetrics and Gynecology, Delhi, Executive Committee member of Indian Society of Assisted Reproduction, Endocrinological Committee of AOGD, and the Infertility Committee of FOXY. Fields of interest are management of all cases of related infertility with special focus on reproductive endocrinology, laparoscopic and hysteroscopic corrective surgeries, assisted reproductive technologies. Now I request Dr. Aba ma'am to deliver her lecture.
Thank you, Dr. Ramaraju, for having me over to this wonderful CME, and my regards to Senior Dr. Professor Raju. It's my privilege to be here in Vizag today. I have never been here before. This is my first visit to this city of Andhra Pradesh, and I'm surely delighted to see what a lovely place it is and such a good gathering on a Sunday morning.
Well, after all the talk by Dr. Ramaraju, Dr. Jay Prakash and Dr. Murali, we now come to a clinician's topic, which is once I was told that it is going to be a collection of gynecologists who get in their clinics infertility patients, and they would want to know what to do once we find an abnormal semen analysis. We all understand that according to the latest WHO manual, which was rewritten in 2010, the volume of a normal semen has to be 1.5 ml or more, count 15, progressive motility 32%, and sperm morphology a minimum of 4% normal. These are the 4 highlighted areas after which we can decide whether the person needs to be further evaluated regarding male infertility. Once we get an abnormal semen analysis, what is the next step? For the clinician, do another semen analysis. Very nicely stressed in our first lecture that one analysis is never enough. If there is azoospermia, we confirm it again by centrifuging the sample at 3000 G, 15 minutes, and do a high-powered microscopic examination of the pellet. which we get on centrifugation, and see whether it has sperms or not. And with that comes a detailed history, physical examination, hormonal evaluation, out of which these 4 are very important, as well as if there is severe oligoasthenoteratozoospermia or azoospermia, then we also need to do a genetic profile, like was told in our first lecture, karyotype for Klinefelter syndrome, Y chromosome microdeletions, cystic fibrosis gene mutations to diagnose congenital absence of bilateral VAS. Imaging may be important, and out of the 2 imaging required for the genital tract, one is called TRUS, a transrectal ultrasound scan, which is done mainly for the male accessory glands, prostate and some anal vesicle, and a scrotal ultrasound to see the testes, the volume, the texture. Post-orgasmic urine analysis, especially where the volume of the semen looks very low, where we find just few drops of semen coming, and especially in males who've had a psychosexual disorder or a surgery in the past. Now, when we say abnormal semen parameters, what does that mean? OATS, the oligoasthenoteratozoospermia syndrome. O is for count, A is for motility, and T is for morphology or shape. I'm just bringing this back to you because we all are general gynecologists may not have access to all the advanced technology or words used in the practice of infertility. Azoospermia could be of 2 types. One is there is obstruction somewhere in the passage of sperms from the testes to the ejaculated semen, or there is no sperm production in the testes at all. And then when we have miscellaneous defects which don't fall into the first 2 categories, then we say, oh, we have a very low volume semen, or it's very viscous, just fails to liquefy, or all sperms are looking abnormal. Say the acrosome is absent in each and every sperm, which is a genetic abnormality. So these would be in the miscellaneous group, which are rare and which we may have to tackle in a different way. So clinically, what are the different sperm parameters which we get? Abnormal one. First is OATS. OATS could be mild. Out of the 3 disorders in count, in motility and in shape, we could have a mild defect, we could have a moderate defect, or we could have a severe defect. Similarly, when we have azoospermia, we have production problems, then it could be because of a hypogonadotropic hypogonadism, or the testes could be failing. And if we have obstructive, then this could be a congenital obstruction or a surgical obstruction. And the miscellaneous group, like I told before, was either low volume, high viscosity, or globozoospermia. So we'll tackle these each on their own merits, but then to tackle all of them, the whole management can be divided into 4 broad groups. The first is lifestyle management, and I think in the first lecture, Dr. Ramaraju emphasized a lot on this management. 2 is medical, 3 is surgical, and the 4th is ART. This goes exactly like management of every condition in the medical world is lifestyle, medical, surgical, and here ART is another addition with an overlap of these managements for one condition. Lifestyle management, I've made it very simple. Very obese male, they need weight reduction. If they are taking a lot of alcohol or they're smoking a lot, reduce the alcohol intake, reduce the smokes. If they wear very tight undergarments like the gymnasts or people who are in the sports world, they need to use loose fitted undergarments, cotton undergarments. Occupational exposure to heat, frequent sauna, hot tub use, especially for people who are working in furnaces or who work in saunas, who help giving Turkish baths. They are the ones who are exposed constantly to high heat. Then anabolic steroids for any reason, and diabetes needs to be controlled very well. Cannot emphasize it more, it has been emphasized earlier also. With this, we go on to medical management. I am not detailing more about lifestyle. Medical management, we've got 3 important facets of managing medically. One is specific therapy, where we have an underlying disorder, where we give therapy, and this is standard therapy which should improve sperm count. 2 is non-specific therapy on the other side of the spectrum. This is totally empirical, and it is for oligoasthenoteratozoospermia where we have got no cause. We can't identify underlying cause. And the third group of therapy is may help therapy. Maybe it would help, maybe it wouldn't help. The may help therapy is by aromatase inhibitors to obese men or antioxidants where we find high ROS, reactive oxygen species. The specific therapy is for only 2 conditions in the male. One is a well-diagnosed hypogonadotropic hypogonadism and established genitourinary infections. So we move on to all these 3 areas of therapy medically, because this is where we as gynecologists can help our patients without having to refer them for higher treatment. Specific therapy, well, hypogonadotropic hypogonadism, this is characterized clinically by low virilization in the man. He looked like a cute man, a sort of softish, womanish looking man. Hypotropic testes, nobody can overemphasize here that the volume of testes is very, very important. And we may find azoospermia. Out of the investigations, the most required are, we find a low follicle stimulating hormone, luteinizing hormone, and total testosterone levels are all low. Causes could be congenital or acquired. Congenital, well known, are Kalman syndrome and Prader-Willi syndrome. Acquired are any pituitary tumors or anything which compresses the hypothalamic pituitary stalk, the gland, or the hypothalamus itself. What is the treatment? Well, it's simple. Once we know that the testosterone levels are low, we start from the first drug, that is human chorionic gonadotropin. And HCG is given in doses of 1500 to 2000 international units intramuscular 2 to 3 times a week. Why 2 to 3 times? Because the half-life is just about 32 to 36 hours of this drug. So it has to be repeated at least in 6 days 2 times. For 3 months, we check again, look at the testicular volume, look at the testosterone levels, and if we find that this has stimulated enough of testosterone secretion by the LH-dependent Leydig cells, then we can start on FSH injections or add on FSH injections to the previous HCG. Now this is given in doses of 75 to 150 alternate day for 6 to 24 months. So at least minimum of 6 months is required, and we can do a semen analysis from time to time to see how many sperms have started coming into the semen. And what happens? Testicular growth happens in almost all, spermatogenesis in 80 to 95% of patients, but we have to make sure that they don't have undescended testes. If they have undescended testes, we can do nothing for them. And this is one study, 2010, which shows mean total testosterone goes up from 41 to 647. The testicular volume combined of both testes from 24 to 33 cubic centimeters, and mean sperm count can go up from 0 to 36 million, where we say that they can father their child without a child without having to undergo any help from any method of ART. Infections of the genitourinary tract, prostatovesiculitis, or male accessory gland infections. When we say this, then we have to establish that there has been some infection presently of either the prostate, the seminal vesicles, the urinary bladder, or the testes. Antimicrobial therapy is standard for this. If there is pyospermia of more than 10 cells per ml, but we have to make sure that we have truly recognized pyospermia. Just 10 round cells which look as leukocyte has no meaning. We have to add a peroxidase staining to the semen analysis sample and make sure that only those which are peroxidase positive are the ones which are leukocytes. The others are round immature sperm cells, and they do not constitute pyospermia. So once we have that, male accessory gland treatment is not for just 2 weeks or 3 weeks like in the female, it is almost 6 to 12 weeks. Then there has been a little controversy over quinolones. Even though the Urological Society advises quinolones as the first line treatment for Maggie, yet we know that quinolones can depress spermatogenesis. They do collect on the sperm membrane, and spermatogenesis could be depressed for as much as 6 months also. Now we have to understand another thing, that what these antimicrobials do, they eradicate microorganism from the genital tract, but they cannot reverse functional deficits or anatomic and secretory dysfunctions which have occurred while the inflammation was on, and while healing of the inflammation happened, a lot of strictures, a lot of gland dysfunction develops. We have to make sure that if we have men with leukocytes in semen, we offer antibiotic treatment only if infection in genitourinary tract is identified, either by adding on a culture of the urine or semen analysis, or examining the male and seeing that there is inflammatory tenderness in one of the accessory glands or the testes. And another thing is anti-sperm antibodies. We do not treat them with corticosteroids anymore because it's very unclear whether these really help, and then corticosteroids are double-edged weapons which could harm a man more than really helping. So now I move on to the non-specific therapy. We've done the specific therapy for both conditions. Non-specific is given for unexplained oats. We don't have a reason, we just do a semen analysis and we repeat it and we repeat it, and we find that either the count or the motility or the structure is grossly abnormal. It affects almost 30 to 45% of men who present with abnormal semen findings. And what is subnormal semen parameter? Anything which is less than normal. And we just defined in the first slide what was normal: 15 million or more count per ml, a 40% or more motile sperms, or a 4% or more normal morphology. So what do we do? What is empirical drug treatment? These are the drugs which I have listed here are used by gynecologists, urologists, andrologists from time and time again just to improve sperm count. Now look at what is contraindicated. Androgens are contraindicated because they will negatively affect the FSH LH secretion and possibly as a rebound might further depress sperm counts. What has very little scientific evidence? Bromocriptine, HCG, HMG injections, alpha blockers, systemic corticosteroids, magnesium supplementation. Recombinant FSH antiestrogens like clomiphene citrate may have some benefit in selected cases. So in general, empirical medical treatment for unexplained oats is not effective. And therefore what happens? There is very little, what is our first lesson we've learned till now? Very little scientific evidence for empirical medical treatment in idiopathic or unexplained male infertility. Medical treatment only recommended definitely where we see an endocrinological problem of hypogonadotropic hypogonadism, and definitely this is grade A evidence, which is the highest grade evidence, which says that we must offer medical treatment to these men and do not refer them for semen donation or IVF-ICSI. Now we come to the third group of may help therapy. Now what is this may help therapy? Might help, might not help. First thing is, we've already heard about the reactive oxygen species. 30 to 80% of infertile men have elevated markers of oxidative stress in the form of reactive oxygen species. Now this is how much of ROS could be present in subfertile male. What is oxidative stress? Well, it could happen due to primary pathologies of male reproductive system, which means accessory gland infections, prolonged stasis of spermatozoa, and immature or abnormal spermatozoa. Or it could happen by environmental lifestyle factors like drugs, smoking, pollution, alcohol. Or it could happen by systemic pathologies like diabetes, cancer, infections, varicocele, and eventually it leads to spermatozoal dysfunction and infertility. To reduce the oxidative stress or to clear out the ROS, antioxidants are used. There are some enzymatic and non-enzymatic natural antioxidants which we all have within us. They normally clear the normal amount of ROS, but when this amount goes above a level, say more than 30% of DNA fragmentation is seen because the ROS is high in that semen, then we need additional support by adding antioxidants to clear out that extra generation of ROS. And the commonly used antioxidants are vitamin E, L-carnitine with L-acetyl-carnitine as combination, coenzyme Q10, ascorbic acid, zinc,